concept of using ctDNA on HCC for curative intent is really interesting and a valuable concept. And the fact that is we learn about circulating tumor DNA from other diseases like colon cancer. And we saw this concept and the technology helped us a lot to identify disease recurrence after surveillance of patients who have curative intent. And also it helped us to identify macro, or what you call it, MRD, minimum residual disease or molecular residual disease after curative surgery, to decide on patient if we need to give them like adjuvant therapy or not, or to do like a surveillance. So the ctDNA from previous studies on colorectal cancer have shown that you can identify the disease a few months before you see it on the scan. So with that in mind, we came with the idea that, HCC, a disease that have a curative intent by surgery or radiation or ablation, ctDNA will provide a big value in clinical management of those patients. Because, we don't have a clear guideline on surveillance of those patients. We do like 3 months, 6 months, and as the time passes, we decrease the incidence of images. But we didn't have a clear guidance on the surveillance of this patient. And also, we didn't have a good biomarker for HCC besides alpha-fetoprotein. And alpha-fetoprotein is not always elevated in the setting of cancer. So we're looking for markers and a biomarker that help us to decide on the management of those patients. Should we give adjuvant therapy after transplant or after surgery or ablation, or should just do surveillance? And if we do surveillance with images, what other biomarker that can help us to identify the recurrence of the disease before it's become full-blown disease and it's widespread? So sometimes we can have another curative intent after recurrence of the disease if it's a localized or oligometastasis. With that in mind, we came in with this concept about using circulating tumor DNA with personalized informed platform to detect residual disease after curative surgery and during surveillance, so we can intervene accordingly. With the data that we have, the cohort 1 with the transplant cohort, and actually in that cohort, all the samples been negative for ctDNA. And interesting enough, none of those samples or none of those patients who have a negative ctDNA have a disease recurrence. So negative ctDNA in the blood showed no recurrence in the scans and in the natural history of the disease or the follow-up of the patient. So that was give us really high specificity and sensitivity of the test. And in the other cohort with surgical resection or curative surgical resection, 30% of the patient who have a recurrence actually had ctDNA positive. So those patients, when we saw ctDNA positivity after surgery, had recurrence of a disease. And that was significantly highlighted. That is, this is a sensitive test and specific for such indication or such use after surgical resection. So with that, even though that the samples is like a limited number of samples, or we have around 70, or total we have 125 patients, and we have the transplanted 64, which is 50% of the samples, and the surgical resection is 41% of the samples, around 52 patients, and the rest were different patient population. But with that, even though this is like in a smaller studies, and we have those patients, with tested, the recurrence of those patients actually was associated with a poor outcome. So we have a test that can detect recurrence of the patient early in time, and those who have a recurrence have a poorer outcome. So this has become a valuable in detecting the recurrence early, where we can intervene early. And we know that HCC, when the recurrence occurred after surgery and or after transplantation, the outcome is poor. So early intervention and using such tests might be promising in the future to utilize as a tool to detect cancer early and to intervene early. That's a good question. The timing between the sample processing and preparing the PCR and to detect the ctDNA in the blood, that actually is get better and better with time. So now we're talking about a couple of weeks after the initial one, which is usually take 3 to 4 weeks. So a couple of weeks to get the result back, that is good. And actually now it's 10 days, depend. But you're right about the challenging of the samples. If we had good samples and the sample processing and preparation of the PCR can be done quickly and easily, relatively. But if the sample is not enough, then, or the sample is not, good quality, then there's a technical difficulty in preparing or producing the test and preparing the PCR for this test. So there's a technical challenges, but it's in general for those patients when we have a surgery or we have a transplant, the explanted liver or resected liver from these surgeries actually usually have a good amount of tissue that we should able to do the test with confidence and effectively and efficiently. The samples that usually we have a problem with is when there's a biopsy and there's not enough tissue, and maybe the biopsy is mixed between normal and tumor tissue, that way you're going to find some problem. But in this setting, after surgery or after transplant, the tissue are usually sufficient to provide a high quality assay. I agree. There is more to be done, and I think this is a concept proofing study. So proof of the concept been done here in this small retrospective study. But to interrogate or involve or to utilize this assay, circulating tumor DNA, in this setting, we need a prospective studies where the test is be done according to the clinical trials or alongside the clinical trials. And also we need a more number of patients to validate what we found. But the study that we published and the trial that we presented in different conferences, actually it's a proof of concept. We expand the utility of the ctDNA in a curative setting for HCC and after surgical resection or transplantation or ablation. So the data so far is promising, but it's not enough for the prime time or to change the practice. We need to expand these studies to a larger numbers, prospective clinical trials in a more controlled setting to provide more validation so we can utilize it and accept it as practice changing or guideline changing, if you will. I'm glad you asked this question because this is the first step in this pathway. And actually, we are preparing prospective studies with multicenter across United States and North America, including Canada, actually, where we can reproduce this work in prospective clinical trials and to have some clinical decision being made based on some of these results of ctDNA, where we can see like if it's positive, can include adjuvant therapy, and if that's adjuvant therapy, really meaningful evidence to utilize this test to make a decision making after curative intent. So to scale up from here is the prospective clinical trials and the multi-center study where some clinical decision will be made based on the positivity or negativity of this test. And that will provide us more of a direct evidence if that test that's so far promising data can be scaled up and can be utilized for clinical decision making, which is, I think, is very promising and might be the case based on what our knowledge that we have from a different type of cancer like CRC and pancreatic cancer. So I think this is our next step is to move forward for scaling up and prospective multi-center study. I want to give the message out that is circulating tumor DNA, just looking back 5 to 10 years, was a concept. And the concept have some promise back then. And we see it, getting an FDA approval and on the CRC and also implementing it in a different setting. And I can assure you that the data so far on HCC, and actually we're expanding it into cholangiocarcinoma now in a different study, but it's coming up. The manuscript is being submitted as we speak. Is the hepatobiliary cancers can benefit from circulating tumor DNA, and these two diseases specifically can maybe benefit more than colorectal cancer, given the natural history of the disease, and the curative treatment for such aggressive cancer might be limited. So these tests will provide a guidance for the future and hold a lot of promise to our patient with such devastating disease.